and colleagues, I'm Pete Waddingham. I'm a Programme Manager with the Yorkshire and Humber Academic Health Science Network, or AHSN for short. Today we just want to talk to you about CVD management in primary care. The webinar is scheduled for an hour. I'm going to try and do it fairly quickly, maybe in half an hour. We'll see how we go. Possibly some time for question and answers, but it might be nice that some of you get some time back to go and have some lunch, because I know everyone's busy. We'll see how we get on. We've got a lot to get through. I don't want to rush it, but also it was only ever intended to be quite a high-level discussion, or high-level overview, should I say. So the plan of action is to give you a flavour of all of the work that we're aware of as an AHSN on national, regional and local CBD resources that are available to PCNs and practices on CBD management. And that includes community pharmacy, who I've got here along today, and Alison Hemsworth is going to take over presenting in a few slides and just give an overview of thanks, hi Alison, of some of the work of community pharmacy. And I'm going to break the presentation down into three areas: hypertension, cholesterol and lipids, and then diabetes. And just very, very briefly, why us as a Yorkshire and Humber AHSN, why are we giving you this webinar today? Well, we're commissioned both nationally and locally. So, for example, we were commissioned by West Yorkshire and Harrogate Integrated Care System to deliver the Healthy Hearts project, and we've been delivering that for a while with those three headings above. We've also been commissioned nationally over the years by NHS England and NHSI. So, for example, we helped deliver the AF project that some of you might have been familiar with, where we went out into practices with the AliveCore device, that little 2-lead ECG. But now we're also getting involved in some of the work around Inclisiran, PCSK9s and FH, and that's what we're going to give you a flavour of. I just want to stress this last point. Do not worry about remembering any of this today. I'm going to go through it quite quickly and quite high level. The main thing that we ask you to remember is just how to contact us, please, and to link with after this call, that I think will be the value. So yeah, we'll make the slides available, the recording available, but yeah, please don't worry about remembering too much of the content. Just in terms of Healthy Hearts, and actually how we're structuring this, in terms of Healthy Hearts, we were looking at hypertension. So how do we increase the prevalence and optimise those treatments of patients already diagnosed with hypertension? For cholesterol, we were looking at a very specific work with Healthy Hearts about statin treatment, but now we're joining it in with that national work around Inclisiran, around Ezetimibe, around PCSK9s and FH, which again we'll give you a flavour of in a bit. And thirdly, the work that I'm doing in West Yorkshire and Harrogate was around diabetes, with a very specific focus about those high risk of CVD, using a drug called an SGLT2 inhibitor. Now, that doesn't mean that's the only thing that's happening on diabetes, but in terms of today, we just want to give you a small flavour of the work that we're doing. I'm going to start with our website, the West Yorkshire and Harrogate Healthy Hearts website. There's the address at the bottom. There's our Twitter handle if you can follow us and go on that website. The information has got information for both patients and professionals, and you can see where I've just put that tab there. You can click on there, and it's splitting down by hypertension, cholesterol and diabetes. We're really proud of the fact that we've tried to do a lot of work around accessibility. So it's got something built in it called Browse Aloud, which if you were as a patient and English wasn't your first language, or you was hard of sight, you could use that Browse Aloud function to just get the information translated or in bigger font or read out to you. We've got some information on there in easy read for those with low health literacy or for those with learning disabilities. So we've created some easy read content. So I'm really proud about that. And this website is constantly getting updated with information that we might find that we think is helpful or changes that we're making. So please do come back to it as a bit of a source of truth. I'll touch on this very quickly. I'm presuming people on this call might be aware of the National Service Specification for PCNs, of which CVD is a focus. I'm just going to have to put my glasses on now. But obviously, there's some money available. The Investment and Impact Fund, it covers lots of area, but today I'm just going to pick out the CBD work. And as of October, there's a real focus that PCNs should be looking at hypertension. And then post April 2022, there's a focus on AF, FH and heart failure. But that table probably doesn't do it justice as well. There's also a need to have a CBD lead in each PCN, which we're hoping we can find some of those in today's call, in some future calls that we do. But yeah, there's some more content in the detail of that. So, for example, there's an expectation that PCNs will review the outputs of the CVD intelligence tools like CVD Prevent. If people don't know what that is, Nationally, they're going to be extracting data from primary care to look at the state of CBD. We also have a dashboard that I'm going to talk to you about in a bit. So PCNs need to be starting to do this as part of that specification, and we'd love to sort of help you with that thinking. Obviously, I've mentioned FH, and there's also a requirement to do some work on statins, which I'm going to talk to you about as well. So let's start with hypertension if we can then. We created a treatment guidance, and again, I'm not going to go into detail on this, but it's on our website. It's for uncomplicated hypertension. It was signed off at a West Yorkshire and Harrogate regional level, and we went through all the area prescribing committees and a range of stakeholders. And at the time, the difference for our treatment guidance was the use of amlodipine as a first-line drug, because it didn't need a blood test. It might therefore help alleviate some pressures in primary care. We then made a recommendation that if blood pressure wasn't controlled, then go on to Ezetemibe. Then the additional use of an ARB, losartan, and then spironolactone. So do check that out. We try to make it simple as possible. You know, it is evidence-based, but as I said, it's for uncomplicated hypertension, and you can find that on our website. There's also, as I said, some information on hypertension for patients, a blood pressure chart, you know, to give them some clarity on what their numbers mean, some useful videos, etc., etc. And on our website for professionals, you'll see the hypertreatment guidance there at the top left. We've created some clinical searches, which again, I'll just touch on very briefly in a minute, and show you where to get them from, how to download them, but they hopefully help practices find those patients that we use the phrase of hiding in plain sight. So who's on the clinical systems that possibly should be registered as hypertensive but are not? How can we help you in a very quick way find those patients? And then on the right, there's lots of other information that you can use for whether it be the access to the new medicine service, because they support the patients that get newly diagnosed with hypertension and put on antihypertensive medication. And as I say, I'll let Alison cover that in a second. So lots of information. Do have a browse around, but again, as I've said, and I will say throughout all of this, please do reach out to us. You know, we know that there's lots of information out there. I don't want you to struggle. Just ask us the question, you know, how can I find this? Where's this? Etc. etc. Yeah, we've got a dashboard. Again, I would love to sort of sit down with people. We've already started reaching out to PCNs. We've got PCN level data, practice level data, just about hypertension. You know, we're not using this as a kind of stick. We're not using it as a performance chart. It's just really to guide, you know, where might the opportunity be for practices for PCNs. So, for example, we know there's about 10,000 patients across Yorkshire, across West Yorkshire and Harrogate, that are on hypertensive medication but not on the register, and we've tried to exclude lots of reasons why they would be on that medication to hopefully leave the patients that we think are those that are hiding in plain sight. And there's also another search around those that have had several high BP readings in the last 3 years, but again not on a register. We just want to give you the tools that might be able to allow you to find those patients quickly. And I sat down with a GP probably just about a month and a half ago, and we did that very thing. And then in the space of about 5-10 minutes, you know, he found 10 patients that he was able to then task nurses in his practice to further investigate. So we hope it's quick and we hope it's effective. There's a couple of digital tools floating around in West Yorkshire and Harrogate. They've commissioned AccuRx, and those messages, as part of those flows, those florries, allow people to be sent a text message to get their 4-day or 7-day readings. The messages are configurable, e.g. you could start putting, you know, signposting information to our website in there, or potentially to community pharmacy, and as I said, we'll hear from Alison in a minute. Sadly, there's a couple of features in there that probably would be helpful, but they're not. So for example, you can't do bulk messaging, so you have to go into individual records to be able to do that. But it's a useful product. It's been commissioned by West Yorkshire and Harrogate, and I've had some really good clinical feedback about this in terms of simplicity. You know, the fact that it just sits on your desktop and you can click buttons and fire off links to people. And the reason, again, that's quite important. I know that's for the at-home BP work as well, but we think we've got around 80,000 patients in West Yorkshire and Harrogate that have not had a BP read in the last 12 months. That originally, before COVID, was about 35,000, so it's significantly gone up. And I think people on this call would recognise that that is because of capacity pressures in primary care. So any digital tool like this that can send messages out to patients asking them to submit readings, I think it can only be a good thing. There's other digital products as well. I mean, we've had we did a webinar recently with System 1 TPP and their product, which is called Airmid Cares. So there's a patient app. You know, you've got NHS login. You can do lots of things in that app. One of which is submit BP readings. The only thing that you can't do at the moment is submit a 7-day or 4-day reading average. But System 1 are looking at that as part of the roadmap. But if you haven't become familiar with that app, you're not aware of it, and I was speaking to a PCN yesterday who'd never heard of it yet, they're on System 1. Do check it out. As I said, do reach out to us. It might be a useful tool in your armoury. Okay, so without further ado, I'm just going to stop sharing my screen, hand over to Alison Hemsworth to just take you through some of the hypertension case finding, and then I'll come back and speak about cholesterol and diabetes.
Thank you, Pete. Hello, everybody. Have you got my slides there, Pete, or do I need to?
Sorry, would you mind sharing them? Have you got them there at hand?
I can find them. Just bear with me. Right, just making sure that that's the one.
Lovely. Yeah, we've got them. Thank you.
Okay. You see that?
Yeah, perfect.
Okay, brilliant. Okay, so good afternoon, everybody. My name's Alison Hemsworth, and I'm the head of services at Community Pharmacy West Yorkshire. It is only a really brief presentation that I'm going to give you today. Most of it's about how Community Pharmacy can work directly with GP practices in terms of managing their CVD patients, but some of it's about some of the other services that Community Pharmacy can offer to these patients, which aren't necessarily in the direct control of the GP practice, but nevertheless will be useful for them to understand as well. So the obvious one to start with is the new hypertension case finding service that Community Pharmacy can offer as of the 1st of October. That date was chosen to coincide with the PCN DES criteria that Pete's already talked about hypertension case finding. There is a service specification up and running. You can have a look at that if you would like to. I can certainly provide that link if you wish to. We're still waiting in Community Pharmacy West Yorkshire for the information on which pharmacies have signed up to the service, because it's an opt-in service, not a mandated service. But we know that at least 135 pharmacies across West Yorkshire have already signed up. The slide that I've got at the moment is the pathway that they're required to follow, but broadly speaking, it's in 2 parts. It's predominantly about patients over 40 who have not yet been diagnosed with hypertension. So it might be an intervention where the patient goes into the pharmacy for a different reason, and as part of that conversation, they get identified that they may be a hypertensive, and therefore the community pharmacies will offer them a clinic check. And depending on the outcome of that clinic check, there are a range of possibilities, one of which may lead to an ambulatory blood pressure monitoring service, and they are required to be able to offer both parts of that service, not just the clinic checks. So although it's called a hypertension case finding service, in the service specification it does talk about the ability for GPs to be able to refer already diagnosed hypertensive patients into that service. However, it's very clear that before those patients start getting referred, that the GP practice needs to have had those conversations with the relevant community pharmacists, so that community pharmacists know that those patients are going or are likely to be going. And also bearing in mind that up until this service came into being, they weren't providing ambulatory blood pressure monitoring, so therefore they may still be in the process of purchasing all that equipment. So the service is live, but some of them are still preparing for it. But from a GP point of view, it might be quite useful if you've got a cohort of patients that you know need for example, an annual BP check, and with the right conversations in place, your local community pharmacist may be able to help you with those patients, and then feedback whatever information comes about as the consequence of that interaction. You'll see in the title of this slide here, I've embedded some links, but they're also at the end on a reference slide as well. So that's the hypertension case finding service. Pete's already alluded to this one, the new medicine service. This is another opt-in service. However, about 85% of pharmacy contractors in West Yorkshire have provided an NMS between April and September of this year. The service was recently updated to include more conditions, and you'll see that those conditions are on the right-hand side of there, a significant number of which CVD patients will come under. This is a service that's actually been had an academic evaluation put around it when it was first commissioned, and what that academic evaluation found, that if a community pharmacist has an interaction with the patient when they first get prescribed a new medicine, they're 10% more likely to remain compliant with that medicine than they would be if they didn't have that intervention. So it's a really important service to be in place. The patient, again, can either be identified by the team in the community pharmacy, or you as a healthcare professional can refer in, particularly if you're a prescriber who's starting somebody on a new medicine. And we would encourage you to do that, because, again, there are incentives in the Impact and Investment Fund and also in a similar incentive type scheme for community pharmacy as well. So, again, a lot of collaboration can go on around this service. Flu vaccination, I don't need to tell you all about what the flu vaccination is about. The important thing here is that this year, as part of the PCNs, it's very clear that whether, irrespective of whether a GP practice or a community pharmacy vaccinates the patients, that all those patients who are vaccinated will count towards targets that are in the PCNs and the pharmacy quality scheme. So by collaborating with your local community pharmacy, you are more likely to achieve your target, and therefore the money that's associated with that target. And obviously CVD patients are a prime target for flu vaccination. Discharge medicine service was a new service as of April this year, and it's actually a mandatory service for all community pharmacists to participate in. You'll see from the graphic on the left that it's a fully integrated system. And this is a system whereby a patient gets admitted to the hospital. If the patient tells the hospital trust who their community pharmacist is that they use on a regular basis, the hospital can send them an admission notification so that the community pharmacy knows that the patient's been admitted to hospital, and therefore any dispensing that might have been going on in the background, they don't necessarily need to do it while the patient's in hospital. And then when they get discharged from hospital, the hospital can make a referral to the community pharmacy to say, these are all the changes, here's a discharge note, these are all the changes that were made whilst the patient was in hospital, and please can you undertake a discharge medicine service on this patient. So the idea is the community pharmacy first of all checks that what's on the discharge note reflects what's in their own records, and if there aren't, then some conversations need to be had either with the patient, with the hospital, or the GP practice. Then required to have a conversation with the patient to make sure that they understand what they're doing with their medicines, and should they get a patient where either they need to signpost him further, or the needs of the patient are more complex than the staff in the community pharmacy can deal with, then they are required to refer them on. So, for example, they might refer them on for a structured medication review with the PCN pharmacists that are building up. And this service is predicated on NICE guidance, that medicines optimisation, the safe and effective use of medicines to enable the best possible outcomes. So again, not something that GP practices can have control of, but certainly need to be aware of, because this service is absolutely hinges on the communications that need to happen across the system to make sure that patients stay safe from their medicines. It hasn't happened yet, but from the 1st of January there'll be a new stop smoking advanced service. This again will be where patients who have been in hospital and have had their smoking cessation advice started whilst they're in hospital, when they are discharged, can then be referred to the community pharmacy to continue that smoking cessation advice and or treatments. We haven't seen the service spec yet, but in the pilot it was an electronic transfer of information to the community pharmacy, and as I say, aim to give support to relevant people. So again, CVD patients should be able to benefit quite a lot from that if they've been an inpatient. And those are just the references. I don't know whether you want to take questions now, no, Pete, or whether you want to wait till the end.
Yeah, we'll keep moving through if that's okay.
Okay, yeah, that's fine. I'll take my slides down.
That's really useful, and I think a nice example of how we all need to be aware of the different parts of the jigsaw. I mean, for me, for example, based on what I've just discussed already, you know, practice could run that search that I described about those that have not had not on the register, not on a BP reading. We could then use AccuRx potentially to send them a message. We could then build into that template, have you considered, or why don't you go to your community pharmacy? Obviously, if them discussions had happened before that, we could start seeing a really nice simple pathway that hopefully alleviates some of the pressures in primary care, and that's certainly what we're trying to do for you, because we know how busy everyone is. So just back to the presentation, then we'll keep whipping through it, and then we can have some questions at the end, or please feel free to put some in the chat if there's anything you want us to follow up on. Just because I've shared my screen again, it's gone back to the beginning, so I'll just get to where we were, which I think was cholesterol, and now it's crashed slightly. Here we go. There we go. Yeah, so yeah, heavily involved in cholesterol as part of both local work and now national. As I said, we've got a website there. Go and have a look at it. We're configuring it as we speak, but as of now, if you went on there as a professional, you'd see the resources on the left to do with our treatment guidance, some searches that we've made available. And in terms of the way we started, that was about putting people on a statin if they were on one who had a Q risk, and that could be a Q risk of greater than 10 or greater than 20, depending on which you thought might be the most priority work to do, because as I said, we know you're all busy, so it might not be that you want to start with everyone just yet. We also had a search for switching patients statin if it wasn't working. So if they were on a low intensity statin, we've got a search that will find those whose cholesterol is not controlled or doesn't appear to be controlled, and then there's that option to switch them onto a high intensity statin. We did a lot of work with patients around statins, around communication. So on the right you can see a lot of letters. So if you wanted to write out to a patient, send them a text, put that link in the text to that letter about why are we switching you, what do we want you to do, where to get some more information about statins. We've done that in both easy read as well. We've made reference to community pharmacy services and some other resources. So yeah, lots going on there, but we want to try and keep it simple, and our work in the first instance was about putting people on a statin or switching. We're now though tweaking that slightly. We've got a treatment guidance, so we with our sort of first part of the pathway, it was the use of atorvastatin. For secondary prevention, it was the use of rosuvastatin. But now there's a second part to come to it. Now I'm just going to give you a flavour of this. This isn't a pathway that's signed off yet. We're just trying to take national information and digest it and make it as simple as possible. So we think, obviously, for primary prevention, there is now the recommendation to use Ezetimibe, and then to use Ezetimibe and bempedoic acid in combination if the HDL level or non-HDL level is not controlled for primary prevention. For secondary prevention, it's a work around the injectables. So whether that be the Inclisiran, which I'm going to come on to in a minute, or the referral into specialist services for the use of a PCSK9. So that's the work that we're currently just doing behind the scenes, just to tighten that up and make sure we've got a clear pathway for people, a prescribing pathway for people, building in that national work that comes out and the use of those drugs. And again, there's a reference to FH on there, but I'm going to talk about that in a minute. So just in terms of Inclisiran, and I said some of the work on PCSK9s, which are referred to secondary care, but Inclisiran, it's a cholesterol lowering drug. It was being approved by NHS England in the first ever NHS Population Health Agreement with Novartis to help prevent heart attacks and strokes in line with the long-term plan. It has been approved by NICE. It can be prescribed in primary care, which is where hopefully we'll get the benefits, the economies of scale. There is a cost associated with it that's getting reimbursed. Now, I'm not going to go into loads of detail in any of this presentation, as I said, but we've got colleagues on the call. So my colleague Adele Bunch is leading on this work in Yorkshire and Humber, and links with the national AHSN colleagues on here. But essentially, it's an injection that's done twice a year, in not only on its own, but in combination with statins, maximum tolerated statins. And there has been studies on its reducing LDL benefits. Just some key messages though from us. I mean, we're not here to sell Inclisiran. We're not recommending it over available lipid management medications. In fact, quite the opposite. That's why we really want that pathway, which I just showed you earlier, to be agreed, and for everyone to sort of see what the pathway is. So for example, We've tried to put work in there around statin intolerance. Sometimes people are classed as statin intolerant a bit too early, so we try and provide a bit of guidance around there. But if all of these medications are controlling people's cholesterol, then there are other tools in the bag to help that, and Inclisiran and PCSK9s and Ezetimibe are certainly those tools in the toolbox. Inclisiran is obviously for secondary prevention, i.e. those who've already had a CVD event, but as I said, the focus should be on the entire pathway. In terms of FH then, just a couple of things. So FH again is a big part of CVD prevention. They're trying to get the prevalence up from around 7% to at least 25% in the next 5 years. And I think there's a ratio of around 1 in 250 patients, and there's been 2 pilot sites that have undertook a case finding exercise, and that ratio seems about right. So just some of the key messages again that we wanted to throw in the mix today is that we have FH specialist nurses who are willing to go out to practices and help them carry out some of the searches that we've got available to help you find those patients that might be on your system who need referring to a specialist FH service, or potentially, as I say, a specialist lipid service. There's also another service around the Child Parent Screening Programme, which is a joint piece of work with NENCAR, North East North Cumbria AHSN and Abbott, who are providing a point of care device for primary care for a year duration with the option to buy that at a subsidised cost. The project's fully funded. It takes around 3 weeks to set up. Abbott will train the staff, and there is a cost associated with it for children being tested. Labid, my colleague, who is coming on the line, if he's not already on there, he's on the line. I can see him in the chat now. Please do connect with us. I mean, I've put the contact details on there, but you'll see him in the chat as well. As I said, we're here to help. You don't have to remember any of this. We just need you to kind of show us, you know, that this might be an area that you're interested in, and let us help you with some of the resources that are available. Lastly, diabetes then. Again, we've been doing a little bit of work. There's some tweaks just been made to this in the background, but we're more or less there. So we're starting to look at a new drug called an SGLT2 inhibitor. It's not really a new drug as such, but it's got really good CVD reducing benefits. It can help people's hypertension, for example, as well, lower their blood pressure. So we've tried to create a very simple treatment guidance using the drug of EMPA and DAPA. There's two SGLT2 inhibitors that we think have a place in this pathway. Again, we've got a clinical search. The search is, you know, they're just in the final stages of testing. We've got the System 1 search ready, but the EMA search is coming. But most importantly, there's some education sessions that we're just going to try and wrap around this. So we've got Professor Stephen Wheatcroft from Leeds looking to want to come out as well with his colleague Rainer Khatib at Leeds, and Wakas Tahir, the GP diabetes lead across West Yorkshire and Harrogate, looking to help. How do we empower PCNs to understand these drugs, where they feature in the pathway, how we can come out and support you. So again, as I said, we just really want to prick your ears about some of this work. We've got some information on our website. There'll be more going on that website as the weeks and months develop. Do check it out, and you know, if this area is an area of interest, reach out to me and colleagues. So just some final messages, and then we can have, you know, 10-15 minutes for question and answers if there are any. But yeah, don't struggle alone. Please don't struggle alone. We know everyone is busy out there, and just reach out to us, because we can help you navigate the different resources that might be suitable. We've created resources. We're aware of other parties that have created some. So, you know, it's irrelevant which you use, as long as there's something that helps you in your practice. I guess do this as quickly and efficiently as possible with the best outcomes for patients. There are lots of happening and changes. So do follow us on social media. Colleague Sarah, who's our comms lead, has put some things in the chat as well about our Twitter handle, which we use. And as I said, check out our website. And you know, like everything, I guess, you know, start simple. You know, maybe run some of the searches, get familiar with them, where they are. Have a look at the treatment guidance. Perhaps, you know, make other staff aware within your PCN about our hypertension guidance. You know, if you haven't already been familiar with it, have a look at our dashboard just to see where you are as a practice, where your biggest opportunity might be, and then decide your area of focus. And as I said, it might be that you can consider how some of that those digital tools will help you. You know, maybe not every patient will have access to you know, digital, but you might be able to release some pressures from yourself by using QRX. We'd love to get 1 rep per PCN to connect with us as an AHSN network. So as I say, we can just have our, you know, someone that we can talk to locally within your PCN and just bring some of this content to life in a bit more detail. There are other parts of the CVD innovation pathway that certainly I'm working on as well, and I was just going to give you a very quick flavour of that. So, for example, there's a company that have got the camera on your mobile phone that can look at people's face, and after 30 seconds can start giving a reading of blood pressure, oxygen saturation, respiratory rate, heart rate, etc. It's not quite yet validated. But we are working with them, and we're certainly having some early conversations with GPs who are interested in that technology. There's some companies that are doing some work around automation as well. You know, how can we help you do things quicker and slicker? And then CVD, there's certainly lots of work happening in the remote monitoring space and platforms, things on heart failure. So just finally from me, yeah, if you've got any question and answers, pop them in the chat. I'm just going to have a look in a minute because I think there's a couple coming in. But the main thing is follow up with us after this event, really. You know, thank you. We know you're busy, so thank you for joining. We've got good attendance today. We've got some more webinars that we're going to be putting on. So if you've got any colleagues that you think might be interested, signpost them our way. Check out our website and do email us and check us out on Twitter. So thank you for that. I'm going to stop sharing my screen and just see if we can read through some questions and see if anyone wants to put a hand up and ask anything of either me, Alison, or my colleagues Adele and Labib. So the first question about, has the diabetes pathway been ratified? It has, yeah. We're just we're making some cosmetic changes more than anything, Claire. It's been ratified. People accept that there's some really good evidence for the SGLT2 inhibitors and that they play an important part in that pathway. Let me read up, some other comments. As a Yorkshire Humber AHSN running. That's the inequality. Sarah, do you want to just 1 minute, if no one else has got a question, did you want a little bit of airtime just to come online and speak about some of the work that you're doing?
Thank you. Yeah, I already put the contact details in the chat, but basically we're working on 2 health inequalities projects. One is with the Care Quality Commission. We're looking, for example, of new ways of working to tackle health inequalities to improve access to services, in particular in deprived areas. The second project instead is with the Health Foundation, and again is about looking at how tackling health inequalities, finding new ways of working, but focusing on 5 specific areas: cardiovascular disease, mental health, maternity, respiratory, and cancer. If any of you has good examples, know anyone who has good example, please share the information and get in touch with our program lead for these 2 projects. Shalom, and I put his email in the chat. So that would be fantastic. Thank you.
Lovely. Well, thank you. I think that was the only question. I could see some people sort of linking with Alison, and as I said, I've always been a fan of community services. I think they've got a lot to offer, and we just need to try and make sure we build it into the pathway. And as I said, hopefully I've given you a flavour of how that might be possible with hypertension. And I'd love to link with any PCNs that are on the call who might be interested in looking at that with the use of AccuRx, etc. So if there's no more questions, I said, go and have some time back, go and enjoy a bit of lunch and hopefully get a well 10-15 minute break if that's okay. Lovely, thanks for joining us.